our lecture series for geriatric health. My name is Barb Cochran, and I'm the director of the DeTournier Center for Healthy Aging here in the School of Nursing. Today I'm representing the Northwest Geriatric Education Center, which is sponsoring this lecture series, and I'm very pleased to have with us today Ron Jackson. He served as the executive director of Evergreen Treatment Services since 1980. He's a graduate of the UW School of Social Work, where he currently serves on faculty as an affiliate full professor. Under his leadership, ETS has developed a research division that has conducted numerous federally funded studies of approaches to changing addictive behaviors. Mr. Jackson is presently the co-principal investigator for community-based treatment programs for the Pacific Northwest node of NIDA's Clinical Trials Network. In addition to teaching at the UW, he has lectured throughout the country on topics related to addiction treatment and public health, and has published widely in the area of chemical dependency treatment. And he's going to talk with us today about aging and addiction, a rising tide. Welcome.
Thanks, Barbara. Hi, everybody, and welcome to my talk. It's interesting to talk about addiction and aging. Being an aging person myself, it's always fun to kind of talk about what the implications of this baby boom generation are as it moves, as a lot of people like to say, like the pig through the python. One of the more stunning statistics I've come across recently is this idea that there are about 10,000 Americans that turn 65 every day and will be doing so for the next several decades. That's a lot of people hitting advanced years, and like many other things that baby boomers do, they bring with them all of their life experiences into older age. There are some data, and I don't have a lot of them, but there are some data that suggest that these folks, the baby boomers that are getting into their late 60s and 70s and so forth, are bringing with them a higher prevalence of illicit drug use than in previous generations, and that has implications not only for their medical care in the general community with primary care practice and the like, but also what happens when those individuals end up in retirement communities, in assisted living, in nursing homes and the like. They are active consumers of medications, and so when you start thinking about drug abuse and the interactions of the drugs that people are taking with the medications that they're being prescribed, that's also an issue as well. And there's going to be an increase in treatment demand for the older population. This projection here was made before the passage of the Affordable Care Act, which may well bring more medical insurance to a wider number of people. Even though Medicare exists for folks, the Medicare coverage for substance use disorders isn't as robust as one might like. For example, I run a methadone clinic, and Medicare doesn't pay for methadone treatment for individuals. So it has got to be a problem for us, as we had some of our older patients who were moving off of Medicaid and on to Medicare, keeping them continued in treatment. Here are some data that come from the most recently published National Survey on Drug Use and Health that looks at the prevalence of past month illicit drug use. And I like to use past month more of a marker than past year or lifetime, because it really speaks to the currency of folks' use. And what you see here is that over the last decade or so, the incidence of past month illicit drug use in the cohort that's just verging upon older age has been increasing. So these folks, like I say, will be carrying that tendency to use illicit drugs as they move forward. Some behaviors drop off with old age. One of them appears to be driving under the influence of alcohol. And so this again comes from the National Household Survey on Drug Use and Health, and you see that the older people are, the less probable it is that they drove under the influence of alcohol in that preceding year. Whether that will continue to pertain is not clear to anybody. This quote comes from Wendell Berry, and I don't like to spend a lot of time talking about addiction causation because it really is multivariate, but I do like this quote because I think it kind of resonates with some of the issues that older individuals face, and that's loneliness and isolation, kind of a loss of self-worth as they retire and are no longer in an active work position, and if they can't find something that gives their life meaning, I think that you end up with that kind of dull or painful life. And so I think this speaks to the increased vulnerability. If you work in addiction treatment, you hear people who start accelerating their alcohol use, particularly after they retire, because they no longer have the responsibilities, they no longer have the constraints of going to work, they no longer have structure in their day, so they find it somewhat easier to drink and drink more often. Human drug-taking behavior, regardless of age, exists along a continuum. Everything from abstinence to experimental use. And people experiment with drugs for a variety of reasons. Most commonly, experimentation is triggered by environmental influences. Their friends do it, their role models do it, it's advertised to them, and so forth and so on. If a person likes the way a drug makes them feel, by that I mean it either makes them feel good or makes them feel less bad, they start to become regular users of that substance. And regular use, regardless of the legality of the substance that the person is taking, typically connotes non-problematic use. It may be pattern use. They may use every day or every weekend or whatever the case may be. But simple drug use generally connotes non-problematic use. As you move along this continuum of use, you end up with abuse, and that's the next kind of category, and that connotes problematic relationship with the substance. And I suspect almost everyone in the audience knows that DSM-3R and DSM-4 started separating abuse from addiction, but DSM-5 does not. The abuse category falls out in DSM-5, and so I'll talk a little. I might as well talk about it now. DSM-5, as the last version that I saw, has 11 criteria for the diagnosis of a substance use disorder, and that's what they're called. They're called substance use disorders. They're not called substance dependence. And a clinician looking at those 11 criteria can make one of 4 diagnoses. They can say no problem. They can say mild problem. They can say moderate problem, or they can say severe. And moderate and severe typically connote addiction. I'll say a little bit more about that in a little bit. So my big concern about the elimination of the abuse category has more to do with misdiagnosis of addictive behaviors in adolescents, and that's not the topic for today. Then we move to this final stage that's called addiction, and addiction seems pretty mysterious to a lot of people. These are intelligent people, and many of whom are sacrificing their health and their resources and their relationships in service of their relationship with the drug, and it seems kind of mysterious. And so I want to kind of work you through a bunch of different definitions here to kind of give you a flavor of what addiction looks like, and then I'm going to end up with the elements of addiction. Alan Leshner is a psychologist and was the former director of the National Institute on Drug Abuse, and he's famous for having gone around the country in the late 1990s and early 2000s talking about addiction as a brain disease, and he did that for 2 reasons. First, as you all know, in science, you can only truly know what you can measure. And so the National Institutes of Health, of which NIDA is one of the sister agencies, spent a lot of our tax dollars in the 1990s developing the instrumentation to look inside the brains of animals and humans to understand what were the neurochemical, brain structural issues that separated mental illness from normalcy, from addiction from normalcy, and so forth. And it became very apparent through the use of this technology that the brains of addicted individuals worked differently than the brains of non-addicted individuals. So it's a brain disease. And the second reason he wanted to talk about addiction as a brain disease was to try to transcend stigma. Stigma is probably the most important dynamic that lessens a person's willingness to talk with a physician or a healthcare provider about their relationship with substances, much less to undergo treatment for it. So it is that sensation that if I'm an addict, I'm a bad person. I have achieved this state through willful misconduct or moral lapse, and frankly, the public has perpetuated that kind of stigma. You may know that in the first two iterations of DSM, addiction was listed as a personality disorder, and basically meaning that addictive behavior connoted some underlying psychopathology, not a syndrome unto itself. So the next quote comes from Nora Volkov, who's a physician by trade, and she's the current director of NIDA. And prior to becoming the director of NIDA, it was in her laboratories. She was the director of neuroimaging at Brookhaven National Laboratory. And it was in her laboratories where the PET scans and the MRIs and the functional MRIs were developed to do this neuroimaging to understand what were the neurochemical correlates of addictive disorder. And she makes the same case here. She talks about addiction as a brain disease, but she does it in a more complicated, more nuanced way. She talks about it being altered cortical activity, and she talks in here about it about decision-making being affected and impulse control and reward valuation being different. If you read that statement and you think about it, this will remind you of adolescence. This is kind of like adolescent behavior. You know, you're interacting with your 15-year-old who has just screwed up, and you say, "What were you thinking?" And you get a blank stare back, don't you? And that's because they weren't thinking. The site of executive control inside the brain, as everybody knows, is the prefrontal cortex, and this is one of the last brain structures to mature. It matures more slowly in men than it does in women. And so that 15-year-old is not thinking because they don't have an intact impulse control system at that point in their life. It turns out that all of the drugs of addiction, not only do they interact with the pleasure or reward centers of the brain, but persistent drug taking downregulates prefrontal cortex activity. And so a drug addict has impaired impulse control at the very time that they're having compelling impulses to use a substance. More about that in a little bit. So it's it becomes a cyclical sort of problem. The next quote comes from the late Susan Sontag, who talks about illness as metaphor and talks about the mysterious. If a syndrome, if a disease is mysterious, it is thought of morally, not medically, and is kind of thought to be contagious. And if you think about society's response to drug addicts over the centuries, it's really been about locking people up. If you think about what happened with habitual drunkards in the 1800s in the United States, they were put in stocks in the public square, and now we have crack addicts being locked up for a considerable number of years, and so forth and so on. So that's kind of worthwhile perspective to look at. Okay, let's talk about what the four circumstances, the four elements of the diagnosis of addiction look like. To be an addict is to suffer from these four things. The first is compulsion and craving. This is how you differentiate a user from an addict. This is actually how you differentiate somebody that has an abuse problem from somebody that has addiction. The first element is compulsion and craving. One of the big changes in DSM-5 from DSM-4 is that craving is so central to the experience of substance use disorders that it was put into the criteria itself. It was only implied in DSM-4, but in DSM-5 there's clearly a statement about craving as one of the elements for the diagnosis. Two things drive craving. One of them is, these are both biological, but I've kind of separated them for two reasons, as you'll see. When you take any of these addictive substances on a regular basis, your body starts developing tolerance to it through the process of homeostasis. And the user experiences tolerance as a diminished response to the drug, which is not what they're looking for. They started taking the drug because it made them feel a particular way, and now the dose that they're used to taking doesn't make them feel that way, and so that typically drives them to taking more or more often or in more concentrated forms or whatever the case may be. Well, the corollary to tolerance is withdrawal. Withdrawal is the rebound phenomenon that the body goes through when the ingestion of a drug to which the body has become tolerant is interrupted for whatever reason. And the withdrawal syndrome is different for different types of drugs. So psychostimulant withdrawal doesn't look like cannabis withdrawal, which doesn't look like opioid withdrawal, which doesn't look like alcohol withdrawal, which doesn't look like nicotine withdrawal. However, there are two common properties to every kind of drug withdrawal, and they're anxiety and drug craving. That's it. That happens. Well, if that's all there was to addiction, its treatment would be pretty simple. You'd simply put the person in a hospital and taper them off of the medication safely so they weren't experiencing some of the more deleterious withdrawal effects that might occur with high-dose benzodiazepines or alcohol, or you put them in a fancy place looking over Malibu Beach and you give them Wolfgang Puck pizzas and Pilates classes and hot stone massages and affirmations, and they'll get better. It's not that simple. As somebody who is a noted researcher in addiction treatment talks about, detoxification is good for a lot of things, but the treatment of addiction is not one of them. Because all detoxification does is get somebody pretty drug hungry. The second type of drug craving is conditioned response. It's exactly like Pavlovian conditioning. People take drugs in the context of a wide variety of internal and external stimuli, don't they? They take drugs when they're happy, when they're sad, when they're bored, when they're angry. Those are all normal human states. But for the drug addict, they've been paired with the drug experience. They've been paired with surges in dopamine and attachment of GABA and all different kinds of things. And they're associated with people, places, and things. External stimuli. If I'm an alcoholic and I've always drank at a certain bar, when I drive from work to home, when I drive past that bar, my mouth's going to start watering. It's exactly like Pavlov's dogs. And so this is these kinds of cravings. This is one of the ways that drug addicts' brains are different than normal people. People who haven't experienced drug addiction, let's say to cocaine, if they're shown a video of somebody smoking crack or they're shown a neighborhood where there's a lot of crack sales happening, nothing happens inside their brain. Something different happens inside the brain of a recovering cocaine addict, even though they've been clean and sober for months in response to those stimuli. This is so important that one of the two essential first tasks in addiction recovery is learning how to deal with drug craving. It's trying to regain that impulse control, understanding that your brain's going to light up, you're going to want to do it, but you've got to restore some of that prefrontal cortex activity. And none of the medications that are used to treat addiction help restore impulse control. The only empirically validated intervention that helps restore impulse control is cognitive behavioral therapy. The second element is loss of control. One of my favorite books about addiction is called In the Realm of Hungry Ghosts. It's by Dr. Gabor Mate, who's a physician, works downtown east side of Vancouver, BC, works with some of the more profoundly addicted, chronically addicted individuals in that part of Vancouver, and he takes his title from Buddhist mythology about people who can never transcend this loop that they're in because they can never get satiated. That's the hungry ghost part, and that's what addicts experience. It's as if one drink is not enough and 16 drinks is not enough. It's almost as if the first ingestion of a substance is a priming dose for triggering more. People can't get enough, and that's what you see. Continued use despite adverse consequences is what puzzles us all. Why do these otherwise intelligent people, why are they doing what they're doing? Why are they putting their health at risk? Why does somebody who knows that they have an appointment with their probation officer the next morning, and that PO is going to take a urine sample used the night before. Aren't they stupid? Right? What's going on with this? And the explanation, that's what you see. When you take a history, you say, tell me about your use of alcohol, da, da, da. Have you ever lost a job because you're, well, yeah. And have you ever, anything ever happened with relationships? Well, yeah. That tells you that this person has a maladaptive relationship with alcohol. Why would they do that? It all has to do with item number 4 there, and that's salience. Salience, as many of you know, is this psychological term that has to do with the relative level of importance of a behavior or activity. People know about Maslow's hierarchy of needs, and that means a relationship with activities that help us stay on the planet. Addicts develop a bottom layer below that one, and that's their relationship with alcohol. People misunderstand addiction as a physical relationship with a substance. It's not. It's an emotional relationship with a substance. It's mad love. So that newly delivered cocaine-dependent mother who leaves the hospital, leaving her baby in the nursery to go out and smoke crack cocaine, is not doing that because she doesn't love her baby. It's because she loves cocaine more right now. And it's breaking that salience that is one of the core efforts in addiction treatment. It's trying to find something that will replace that in your life. Not an easy thing to do. In DSM world, to get the diagnosis of current substance use disorder, these symptoms have to be present in the last year. Okay. I think it's important, particularly with people who develop tolerance to medications, to understand the difference between physical dependence and substance dependence. They are not the same thing at all. If I, God forbid, got in an automobile accident this afternoon after I left here and had my hip and femur shattered, I'd be in a lot of pain. And the treating team would probably be prescribing me powerful painkillers. And if I took them for a few weeks, I'd develop tolerance, wouldn't I? But does that make me an addict? No, it does not. It depends on what I do with that prescription. If I'm starting to shop around to 5 or 6 different doctors to get different prescriptions for Percodan or OxyContin or Vicodin, if I'm starting to sell my body for more drugs on the street, that kind of connotes addictive behavior. In DSM 1 through 3, physical dependence was sort of the bottom line for the diagnosis of addiction. You had to have tolerance and withdrawal in order to be adjudged substance dependent. That changed in DSM-3R to recognize that this was more of a behavioral involvement than a physiologic involvement. So you could be diagnosed as substance dependent in DSM-3R and DSM-4 with or without physical dependence. In DSM-5, if you are physically dependent on a medication that is prescribed to you, that you are taking as prescribed, that tolerance and withdrawal doesn't even count toward the diagnosis of addiction. That's a big change. It recognizes the difference between physical dependence. So from this point on, I'm going to talk mostly about addiction rather than substance dependence. It's important for all of us to keep in mind that addiction is rarely caused by one single factor. It's rarely just a matter of genetics or just a matter of environment. It's a complex interaction of all of these things. This is Dr. Volkov's slides, thanks to her, and it talks about how the various things contribute to addiction. If you impoverish a people and you remove them from their spiritual center, and you give them no viable activities, and you surround their community with cheap liquor stores, what do you think is going to happen about the rate of addiction? So it's never as simple as, well, these people have a genetic propensity toward addiction or whatever the case may be. It's also true that drug-taking behavior changes the brain and sort of works it in a direction of addiction. This is an important article. I recommend it to you highly. Dr. Tom McClellan, who's a psychologist and is on faculty at the University of Pennsylvania and is the executive director of the Treatment Research Institute in Philadelphia, and most recently was the Deputy Director of the Office of National Drug Control Policy, was asked by the Journal of the American Medical Association back in the late 1990s to write this article along with a number of other noted addictionologists, basically to change the conversation about addiction. A lot of people, patients and their families particularly, like to think of addiction as an acute disorder, where you go to rehab and you get fixed. You take a medication for a short period of time and that takes care of it. Wear those patches for a couple of months. It's not that simple. And so this article was an attempt to change the conversation. That conversation change is happening very, very slowly because it's not what people want to hear. They want to hear about getting cured, don't they? So like other chronic medical disorders, it runs in families. There's a heritability factor to it. If you had a room full of 100 alcoholics, 50 of them roughly would be family history positive, 50 of them wouldn't be. But like other chronic medical disorders, hypertension, diabetes, runs in families. Fine. But you can also behave yourself into addiction without any genetic history, without any family history whatsoever. That also is true of other chronic medical disorders, right? Type 2 diabetes, prime example, without any family history of diabetes, by the way that you eat, by the way that you don't exercise, etc., you can behave yourself into a circumstance where you have a problem controlling your blood sugar. Nobody thinks of that as willful misconduct. Nobody thinks of that as a consequence of moral turpitude, but somehow addiction is seen a little bit differently with that. It's also true that when you behave yourself, when you into these chronic conditions, there are physiologic changes. There's pathology that happens in the case of addiction at a brain level. That, as I've made the case hopefully several times, the brains of addicts are different. They're different than they were before they started their addiction. There's a downregulation of certain neurotransmitter sets. There's an upregulation of others. It's an imbalanced system, and it's going to take a while for that to be rebalanced. And sometimes that rebalancing is going to need the help of medications, which is where I'm headed next. A lot of people seem pessimistic about addiction and its effective treatment because most people see the folks who don't do well. They see the person that multiple relapse, the Lindsay Lohans of the world, and the John Belushis, and so forth and so on. But in point of fact, the outcomes for the treatment of addiction are very similar to the treatment of other chronic medical disorders. People like to define addiction as a chronic relapsing disorder. You know, so are all chronic medical disorders. Do people that have diabetes when they're on a cruise forget to monitor their blood sugar and put their medicine away and say, I'll worry about that when I get back to shore? Do people who have hypertension sometimes forget to take their medication? So compliance with medication, compliance with physician instructions are relatively common in the treatment of other kinds of chronic medical disorders. And as I'm sure everybody in the audience knows, most of these chronic disorders need more than just a medication in terms of an intervention. They also need some behavior and environmental change as well to get the kind of robust success that you would like to see for your patients. Why is any of what I've said important? It's important to think about the role of medications. People tend to want to think that medications that are used to treat addiction are curative. They are not. They are simply management tools. The lisinopril that my physician prescribes to me for my hypertension is not curing my hypertension. It's helping me manage it to keep my blood pressure within limits so that I don't stroke out. The same thing is true with methadone or buprenorphine for the treatment of opioid addiction. These are not drugs, medications that help reset the brain of the opioid addict. Rather, they act as a platform of neurochemical stability. So treatment is not, medications aren't curative, and what we do in addiction treatment when we use medications is try to teach the patient how to use these properly, safely, and how to sort of not just take the medication, but begin the very difficult process of behavior change and environmental change. I mentioned that one of the two first tasks of addiction recovery is learning how to deal with drug craving. The other essential first task is resocialization, because who does a drug addict and alcoholic socialize with mostly? Other drug addicts, other alcoholics. Well, if they're going to try to change their life, they can't hang with the same bunch of folks. So let me talk specifically about some of the clinical issues that come into play when people get older. As the brain ages, there's a bunch of changes. Cognitive deficits start to occur. Some of those cognitive deficits may be accelerated by the person's long-term alcohol use, for example. There was an article just in the New York Times yesterday about the decrease in physical size of the prefrontal cortex as it relates to both sleep and impulse control. Well, if the prefrontal cortex is the site of executive function decision making, if it's down regulating or shrinking as a result of aging, there's going to be impairment in decision making as well. As the person gets older, their metabolism slows down. So as many of you who prescribe medications to older individuals, you need less of a dose. And you need less of a dose not just because of slow metabolism, but because of the change in the relationship of lean body mass and total body water. What do I mean by that? Well, I'm 67 years old. If I have 2 standard drinks of alcohol now, I have a higher blood alcohol concentration because I have less body water than I did if I took exactly those same 2 drinks 20 years ago. It's the same amount of alcohol, I'm the same guy, but I'm going to have a difference in blood alcohol concentration. And not a lot of people understand that. Not a lot of older patients understand that necessarily. A lot of the drugs, particularly sedative hypnotics and other depressants, interfere with coordination and balance. Those are already starting to be compromised in the aging brain. And so intoxication, impairment can be a source of falls that can lead to problems that compromise the person's mobility, making them even more sedentary, more isolated, you get the sense here of what's happening. People, as they age, typically start having medical conditions that often need medications. The rates of hypertension and so forth increase. We have in our state, and I'm not sure of the status in other states, but I suspect that everybody listening has a prescription monitoring program. I can't emphasize enough how a prescriber's accessing the prescription monitoring program about their patient that they're about to prescribe a medication is. This is one thing that really helps protect the health and safety. It helps you cannot necessarily rely on a patient telling you every prescription for a controlled substance that they're getting from every provider. Not necessarily because they're trying to hide it from you, but they may have forgotten. Just that simple. So I'm a big advocate of the use of the state's prescription monitoring program. So if you haven't had a chance to engage with that, please do that. States differ in terms of who has querying authority. In our state, it is anybody that has Schedule 2 through 5 prescriptive authority. So that means in addition to MDs and DOs, ARNPs, PACs, pharmacists have prescriptive authority and so forth and so on. So in other states, it's limited to physicians. So please think about using this very important tool to understand about what your patients are taking. There are also social changes. There's losses. There's losses of spouses and partners. There's losses of friends. There's isolation from family members, and so forth and so on. This is back to the quote that I gave you from Wendell Berry, that can make the environment for that person very different than it was when they were 30 and 40 years old. There's some data that would suggest that there is an increase in mental health disorders, depression, for example. And so, in my experience, the presence of mental health disorders makes it even harder untreated mental health disorders, makes it even harder for that addicted individual to change on their own. What epidemiologic data seem to suggest is most people who have substance use disorders are able to change on their own. I don't mean most, I should say the majority are able to change on their own without any formal treatment. They go to AA or NA, they join the church, they do whatever has to happen. There are two kinds of folks who seek drug treatment. One are people who are made to go there. They're made by the criminal justice system or their employer or their spouse. But the other people are people that have very complicated chemical dependency, and by that I mean not only are they addicted, but they also have untreated mental health disorders, they have untreated medical disorders, making it very, very complicated for them to quit on their own. So keep in mind, the more complex the patient's case is, the higher the probability if they have addictive disorder, they're going to have a tough time. The other thing I want to talk about here quickly is, and it's not on this particular slide, but I want to talk about that intersection between pain and addiction. All throughout the Northwest, there has been a burgeoning problem of prescription opioid abuse by people of all ages. I don't know what that means.
It's a fire.
Does that mean we have to leave?
We'll have to evacuate to the bridge. Stand by, distance, students.
Okay, well, as I was saying,
Before you were
so rudely interrupted.
Yeah.
Thanks, everybody, for hanging in there. This was an interesting exercise for us all to go through. I want to move on. There are a number of social issues and funding issues that pertain to older adults that I may not have enough time to touch on now that we've only got a little bit of time left to go. We have about another 20 minutes.
Well, we can go till 5.
We can go to 5:30. So thanks, Barbara. We'll go to 5:30. So one of the things that I wanted to focus on were medications that are available. Regardless of age of the person that's suffering with addiction, medications for their treatment, for their management are notoriously underutilized. So I want to talk about what are FDA approved, and in the case of alcohol, a medication, valproic acid, that it might prove useful. So let me talk about these medications. The first medication. Oops, sorry. I want to go back there. The opioids can be addressed one of three ways. There's full agonist medication, that's methadone. There's partial agonist, which is buprenorphine, and then there's an antagonist, which is naltrexone. Naltrexone comes in a couple of different formulations, and I'll talk about that. As a methadone treatment provider, somebody that runs a clinic that has 1,500 patients, we have an aging cohort of folks, and we're trying to figure out how to make our services more salient to those folks. What do I mean by that? So a lot of our recent admissions have been younger adults, people in their 18, 20, 22, 25 years old who are coming in, whose life history has been one of initial addiction to prescription opioids and then migration into heroin. And they're relatively new to their addiction as compared to some of our patients who have been with us for 5 or 10 or 15 or 20 years who are in their 50s and 60s. Our oldest patient is 78 years old. And so some of you know that in methadone treatment, the goal is largely to kind of keep people in treatment, that they do better in methadone treatment than they do outside of methadone treatment. But how do we change our interventions to address the needs of somebody that's now 65 years old that came into treatment when they were 45 years old? Or what do we do about patients who are sent to us from pain clinics that no longer feel comfortable prescribing methadone or OxyContin to that individual for pain? And is the person really an addict, or is this just an undertreated pain patient? And so that's a difficult thing for us to sort out. But methadone's a daily medication. It has to be dispensed through licensed clinics. Physicians can't prescribe it for the treatment of addictive disorder. They can only prescribe it for the treatment of pain or any other condition. And methadone clinics can only dispense it for the treatment of addiction. We can't use it solely for the treatment of pain. If a patient has both pain as well as addiction, we can use it for both of those conditions. People remain physically dependent on methadone, but this provides patients a platform of neurochemical stability that they can use it. For folks that are in Wyoming and Montana, access to, and for that matter Alaska, access to methadone treatment is pretty difficult. The same thing is true in Idaho. There's, I believe, only one methadone clinic, maybe two now, and they're both in Boise. I think there's only maybe two clinics in Montana. I'm not even aware where there's one in Wyoming or not. There are only several in Alaska. So getting people who might benefit from methadone treatment, regardless of age, into a clinic is a daunting task. Buprenorphine is a partial agonist, but by that I mean it energizes the mu-opioid receptor site, but only to a lesser degree. The advantage of buprenorphine, which is also a daily oral medication, is it can be prescribed by physicians, and physicians only, and not nurse practitioners or PAs, because it was put together, the licensing authority is subsequent to the Drug Abuse Treatment Act of 2000, an act of Congress, and that act stipulates that prescribing authority is only for physicians. Schedule III drug. It goes by the trade name Suboxone, which is a combination of both buprenorphine and naloxone. Some of you know naloxone as Narcan, which is a opioid overdose reversal medication. When combined in this oral medication, not much of it is absorbed. It goes also by the trade name of Subutex. That's the mono form of it. In the case of, since we're talking about geriatric patients, I'm not going to talk about the use of these medications in pregnancy. Naltrexone is either an oral medication or a time release or extended release injectable medication that goes by the trade name in the injectable form of Vivitrol, and it is to be used with detoxified opioid addicts. You can't give it to somebody who is in active addiction. They have to be opioid free for a while, and that while may be a few days, it may be a little bit longer. It's sometimes a tricky induction. This medication is also FDA approved for the treatment of alcohol dependence. This blocks the mu-opioid receptor sites, and so when people use opioids, obviously they get a flood of substances inside their brain that are going to attach to those opioid receptors, and that blocks it from happening. The advantage of Vivitrol is that it evades the whole issue of compliance. Once you've got an injection of Vivitrol, you have blockading effect for the entire month. Some state plans cover it, other state plans don't. I'm not quite sure whether Medicare covers Vivitrol or not. It's an expensive medication. It typically goes for about $1,000 an injection, and one of the rationales for using it is that it's a cost avoidance technique. So, somebody that is is alcoholic and using a lot of alcohol and falling down and going to the emergency room a bunch of times, or suffering from hypothermia because they're passing out of doors, or whatever the case may be, it's a cost avoidance. When it comes to alcohol, there are 3 that are approved by the FDA. One of them, the oldest one, is disulfiram. The complication with using Antabuse with people is that A, they have to stop drinking, and B, they have to have an intact liver. The package insert will tell you about the kind of liver function tests and what values you see there in order to start somebody. Acamprosate is the newest medication. It goes by the trade name Camprol. It tends to help reduce some of the effects of prolonged withdrawal. The anhedonia, the problems of sleep, the low mood that people have that persist long after the acute withdrawal symptoms from alcohol go away. The upside with acamprosate is you can start it without the person having stopped drinking, but the downside is that it's a 3-time-a-day medication, so you end up with compliance problems. So somebody that's suffering with memory loss, that's aging, you've got that kind of problem. And then naltrexone, an oral medication. Again, the person doesn't have to have stopped drinking in order to be able to go on this. But with the oral medication that's known as Revia, it's a daily medication. Okay. So just to be clear, for cocaine and methamphetamine, there aren't any approved medications. There's some ongoing work, but right now there's nothing on the market for cocaine or methamphetamine. Nicotine dependence, a not uncommon problem among aging populations. You have a variety of different medications that can be used. Bupropion, varenicline are perfectly good medications to use for folks. Varenicline has some side effects in some individuals. You probably know about those already that can induce some psychotic behavior in folks. So you got to really have to sort of monitor the patient quite closely after starting that medication. It's more likely that your older female patients are still addicted smokers than older male patients. Nicotine dependence seems to persist longer in females than in males. And there was some data that I saw a few weeks ago that only 1 in 4 males who was well, I better not say it because I'm not quite remembering it all the way. So there you have it. There are no medications to treat cannabis dependence and nothing for amphetamine or methamphetamine. I think one of the issues that clinicians are going to face is as the medical marijuana or the legal marijuana movement widens is what's the proper use of medical marijuana in aging populations, since marijuana does affect memory, does affect psychomotor coordination. It's going to be a cost-benefit kind of equation, like every treating clinician does when they start thinking about a medication. Do the benefits of the relief of pain or the reduction of spasms in the case of MS, how does that fit with the problems of awareness and concentration and balance that might be there? People resist medications for the treatment of addiction. First of all, people don't want to talk about their relationship with substances with clinicians. In many cases, the challenge that you have is broaching the subject in the first place. I guess I come from a place where I would recommend that you do a screening about the patient's use of alcohol and other substance as part of your routine health screening. In other words, these are the questions that we ask everybody. When I go to a new physician, I'm given a self-report form and I fill out, and it doesn't ask nearly the kinds of questions that I think need to be asked. Do you drink alcohol? Yes or no? Yeah. Do you smoke? Yes or no? No, but not did you smoke 5 years ago or 2 years ago, or did you quit yesterday, or whatever the case may be. So I think that there are important lessons to be learned about doing screenings about the person's relationship. There's, of course, cost. There's the burden of taking medications and so forth and so on. If people are, sometimes family members are resistant to their family member taking a medication for addiction. They say, well, this is just a crutch. Well, you just need to go to more meetings. One of my favorite quotes from a Texas singer-songwriter named Guy Clark is, one man's crutch is another man's wing. And I've always thought that that's an apt statement, that sometimes people need that kind of help. These medications are not necessarily medications that an addicted individual has to take indefinitely. Sometimes people can use them as a platform of neurochemical stability to change their lives. Other times, people have to take them persistently. And much like is true with other chronic medical disorders, you as treating clinicians can't really make an educated guess in telling your patient how long they're going to need to be on buprenorphine or how long they're going to need to be on. I have a friend whose mother died recently of cancer, and she was an addicted smoker her entire life. And the last day of her life, she was still chewing Nicorette gum, even though she hadn't smoked any cigarettes for 10 years. And she had to be okay with that, and her family had to be okay with that, and not pressuring mom to give up that gum, because if mom was pressured to give up the gum, she'd be back to smoking, and so forth and so on. So there is a negative perception about addiction treatment medications that has to be kind of considered as you're talking with somebody. I strongly recommend that you all read the most recent motivational interviewing text by Bill Miller and Stephen Rolnick. It's called Helping People Change. It's the 3rd edition of motivational interviewing. And the beauty of it is that it helps clinicians approach behavior, helping to facilitate behavior change in folks. That a strong warning from a health provider to a patient may not get the kind of behavioral change outcome that you wish that it would. And the use of motivational interviewing is to try to work the person into a place where they would be willing to consider and then start preparing for the change so that they own the reasons for change. The other thing that I want to talk about with the use of medications is that it's also very clear that addiction should be thought of as a chronic medical disorder for which medications assist the treatment, and it's not a medication alone. You're probably not doing your patient as much good by just writing them a prescription for Suboxone and having them come back in a month with a quick check-in about how are you doing. It often requires urine monitoring to see about patient response, behavior change. Remember I talked about how this downregulated prefrontal cortex does not change by medications. The medications that I've talked about only do things such as alleviating some of the prolonged withdrawal symptoms, attenuating the reinforcing effects of the drug, rebalancing the brain in the case of a camprosate, blocking the effects of the drug in the case of antagonists. They don't change the person's environment. Taking methadone doesn't make a homeless heroin addict get a house. They need other kinds of things. And so there you are. So what if you're referring somebody for addiction treatment? What should you expect is going to happen there? Well, one of the things we've talked about already, and that's providing people tools. I was talking during our surprise break with one of the audience members here who's a gerontologist, and she was asking me about research in addiction in aging populations, and it really is pretty lacking, to tell you the truth. And that's because most of the research about drug-taking behavior and its treatment has been with adolescents and relatively young adults. You don't see randomized controlled trials where the patients are recruited who are over 65 or over 70 years old. And so it's hard to know what specifically needs to change. There is a movement in the fellowship support group to have AA and NA groups for older individuals because they can't necessarily relate to the stories of the people who are 25 and 30 years old. It's a cultural shift. Most of the outpatient addiction treatment that I'm aware of is delivered through group process. And is it appropriate for a 72-year-old retired individual to be sitting in a group with 20 and 30-year-old people that have never worked a day in their life and come from a very different place? So there's not much attention to specialty care for aging addicted individuals, and there's not much research to inform that. And so you have to use your clinical experience, I think, about how to make the interventions appropriate for those folks. I don't think that you can necessarily rely on the fact that your community-based addiction treatment program is going to have a geriatric-specific, evidence-based practice to provide them. That was a mouthful. Here are the behavioral interventions for which there is empirical support. I've talked already about cognitive behavioral therapy. This is basically teaching people, first of all, having them inventory their environment their daily life and figure out where the predictable triggers are and learn new behaviors to deal with that. That's what CBT is. A motivational enhancement and motivational interviewing are something I've already alluded to, that understands that people vary in terms of their readiness to change. And you shouldn't think of readiness to change necessarily as a universal kind of phenomenon. What do I mean by that? Well, we have people who come into the methadone clinic and they may be in action or preparation as it relates to their relationship with opioids, but not thinking at all about their relationship with alcohol, not ready to change their relationship with alprazolam whatsoever. And so all of those are kind of woven together, but the readiness to change is not necessarily on the same page one by the other. And so the same thing is going to be true with aging individuals. They may be ready to quit drinking, but the people that they live with are not, are drinkers, and they are going to, what am I supposed to do? Move out, and where am I going to move to? And so forth and so on. I'm not going to say much about community reinforcement. Relapse prevention is a variant on cognitive behavioral therapy. I would recommend Dr. Alan Marlat's book to you called Relapse Prevention. There's a lot out there, and you can, if you just Google relapse prevention, you'll find a number of guides available online about how to do it. Motivational incentives are simply paying people for pro-recovery behavior, either with tokens or with cash money. And there is a body of evidence that this is an effective intervention to help people get into pro-recovery behaviors, leave drug-free urines, attend meetings, and so forth and so on. There's a lot of empirical support for that. So for treatment to be effective, it has a lot to do with who comes to treatment. It has to do with how individualized care is. If your patients are going to a treatment clinic where everybody gets exactly the same intervention, regardless of the nature of the problems they have, they're not likely to be retained in treatment, and they're not likely to do well. If this is a chronic medical disorder, it stands to reason then that length of treatment is important. The addiction treatment field is slowly migrating from an acute care orientation. You get treatment for 90 days, you get treatment for 30 days in a hospital, whatever the case may be, to more of a chronic care model. You may get an acute treatment intervention because of the acute needs that a person has, but then they get engaged in continuing care in much the same way that a primary care physician might have their first encounter with somebody because they are having problems with blood sugar control, or they're having problems with breathing, or whatever the case may be. But that one intervention or short series of interventions that primary care physician or physician team understands is not going to be the end all. One of the interesting developments is how the Affordable Care Act and the whole health home movement is going to integrate behavioral medicine into it, behavioral interventions. How integrated in a health home is going to be addiction treatment interventions. So I've got a series of resources. These are all available. They're all public domain. They're all online. NIDA-Med is a innovation by the National Institute on Drug Abuse, and it has a lot of resources for healthcare professionals as it relates to assessment and medication use and so forth and so on. I would recommend to you also the clinician's guide. It comes from NIAAA. It helps you understand more about how to do assessments using, for example, the audit, the alcohol use disorders inventory test. It can be a self-administered or other administered document that has validity in picking up problems. It talks not just about quantity and frequency of the person's alcohol use, but life consequences as well, AUDIT. And so that's all available within that NIAAA website. We only have about another 8 or 9 minutes left, and so I wanted to leave that amount of time. I actually would have liked to left a little bit more, but reality intrudes. Fire alarms go off whether we like it or not. So I'm curious what kind of questions folks have. Please.
I work with turn my mic on. I work with elders here in Metlakatla, Alaska. Been CNA for 18 years. I guess there's not a question.
Thank you for your work.
She's still typing.
Oh.
She might have hit enter before she got done with her question.
How can we get more families to be involved with elder drug abuse?
This is a stigmatizing disorder, and not only is the patient feel stigmatized by having it, but family members do as well. What do I mean by that? If you take a look at the mental health movement, there are organizations of families that have bonded together to act as advocates. You don't see any equivalent to the National Association of Mental Health Advocates for addicted individuals. In many cases, addicted individuals have become estranged from their families. Because they are concerned about their behavior, whatever the case may be. Trying to get families involved is very difficult, and it begins by trying to do some education about whose fault it is or isn't that the person that they're concerned about is behaving the way that they do.
So there's another question that's asking if you would mind reviewing the salience of use under
Sure.
elements of addiction.
Sure. It means the relative priority of a particular behavior or object. What do I mean? If you take a look at the drugs of abuse, they either directly or indirectly affect the limbic system of the brain. They cause a dopamine surge inside the brain. The most predominant ones that do that are cocaine and methamphetamine, but others engage it as well. And so the brain begins to learn that this behavior is more reinforcing, is more pleasurable than other kinds of behaviors. And so that begins to take control of the person's life. And it's not logical. It's not really a chosen thing. It just happens, and it happens perniciously. And that's what salience means. And breaking that salience is a very, very difficult thing to do. It's not just a matter of what am I not going to do. I'm not going to drink anymore, or I'm not going to smoke crack anymore, or I'm not going to do heroin anymore. What am I going to do instead? Because in many cases, drug-taking behavior ends up being a coping mechanism. It fills people's time. It helps them deal with on a short-term basis, it helps them deal with the miseries that they're experiencing. Okay, you take away that coping mechanism, what are you going to put back in its place? I hope that explains salience. Jerome Jaffe was the first drug czar under President Nixon, and he's famous for a definition of addiction that I've always liked. He defined addiction as another person's intense preoccupation with a substance or activity that you yourself find irrelevant.
So this is a question, is methadone treatment changing one addiction for another?
When people ask me that question, it connotes that they misunderstand the nature of addiction. Addiction is not about a physical dependence. It's about a lifestyle that's enmeshed in the getting and taking of that particular substance. Somebody that's a heroin addict doesn't have a life outside of heroin addiction. Their whole life, that salience, is centered around the getting and taking of this particular drug. Putting somebody on an orally effective, long-lasting medication that reduces or eliminates the craving for heroin helps that person start to move in a recovery trajectory. If you want to read more about that, you can read the Office of National Drug Control Policy. They actually have a position paper that is issued in support of the use of methadone for the treatment of opioid addiction. NASDAD, the National Association of State Alcohol and Drug Directors, has a similar kinds of position paper as well. So when somebody says that, it's not swapping addiction, it's using a medication to which they are already tolerant to help get a platform of neurochemical stability. That's I can't say any more clearly.
What are some coping skills for families who have to deal with the addict?
Patience. I think more than anything else that because you want them to change doesn't mean that they're going to want to change. It's hard to watch somebody that you love destroy themselves. It's hard, and it's hard not to take it personally. The sort of, if you love me, you'd quit. If you loved your grandchildren, you'd quit for them. It's not that simple. And so it is about support and love, but not enabling. What do I mean by that? It's not bringing grandma over a fifth of whiskey because she's getting in trouble with it. It's saying, I'm concerned about your alcohol use. Let's figure out a way together so that you don't rely on this anymore, so that we can help out. It's working with the treating medical team, the primary care physician, the visiting nurse, the people who work in the assisted living to try to. It really does work best when we approach addiction treatment from a teamwork perspective.
Can you comment on the evidence for use of education and feedback about normative drinking for older adults seen in primary care? Is there good evidence that that approach is effective for older patients?
Not that I'm aware of. There is good evidence that it's effective for the highest risk drinkers in our, some of the highest risk drinkers in our society, and those are college students. So Dr. Marlatt and his group have done a number of studies here at the University of Washington looking at the education, to telling people about, you're drinking you may think you're drinking what normal people drink, but in fact you're drinking 2 or 3 or 4 times that rate, and that exchange of information helps reduce the rate of high-risk behavior. I don't know if it has been replicated in older populations.
And this person is saying that she deals with cultural issues with addiction, in that people don't question elders. So
I'm assuming that I'm talking to somebody that's in a Native American or First Nations or indigenous kind of situation, and that's true. I've done some work with folks in Alberta, in First Nations and indigenous persons, and it's true. Challenging, questioning, asking what's going on is a very difficult thing to do. So the person that's asking this question should probably talk with other elders in that tribal community to figure out the best way to approach that person that is having trouble. It may well be that the clinician doesn't approach that person. Somebody else within the tribe who is a respected elder of that person's age addresses that. There has been ongoing research about the treatment of addiction within the cultural context in Native American communities here at the Alcohol and Drug Abuse Institute. So I would encourage this person to correspond with Dennis Donovan, who is the director of the Alcohol and Drug Abuse Institute. They can do that by just Googling ADAI and trying to interact with him, or Lisa Thomas. She's another researcher here at the University of Washington that has expertise in working in tribal communities.
So you have a slide that's on clinical issues, and the last bullet on there is access to treatment, Medicare. Can you say a little bit more about that?
Yeah, I alluded to that a little bit earlier when I talked about how if the person is looking for methadone treatment and they have no source of funding other than Medicare, that's going to be an issue. I'm not sure the degree to which Medicare covers some of the medications that I'm talking about. And I'm not sure the degree to which Medicare actually covers outpatient counseling or residential treatment for those individuals. And so that's going to be as compared to Medicaid. I know about Medicaid. I know what is available there, but Medicare and access to community-based interventions is not known to me. And I suspect it varies a little bit.
Can you comment on valid and reliable assessment tools for older patients?
There aren't any that I'm aware of. I think you have to sort of look at the audit. We'll use that as an example, or the assist as it relates to alcohol. And those are built. The audit is was developed by the World Health Organization, and it was more in a non-geriatric population. So the amount of alcohol that they talk about as level of concern is probably more alcohol than would create a concern if it were being consumed by an older person. So, for example, for males generally, the safe amount of the moderate alcohol use is sort of defined as 2 drinks per day, standard drinks, not 40 ounces. 2 drinks a day or no more than 14 drinks in a week, and for women it's about half of that. If I were a guessing man, and I was working with a 70-year-old male, I'd be thinking the female guidelines. I'd be thinking 1 drink a day, 7 drinks a week ought to be thought of as moderate and within safe limits. Anything more than that would start to raise concern, particularly if I saw other kinds of things, such as hypertension, such as bruising from falls, right? Those kinds of things, such as problems with malnutrition and the like.
Would you speak to the value of SPECT scanning and feedback as a component of drug or alcohol treatment?
I don't know what SPECT scanning is. Somebody want to tell me?
I'm assuming it's some sort of a brain scanning, but I don't know.
Who's going to pay for that?
Okay, let's see. Medicare.
Maybe, really. I once saw a video of Dr. Volkov doing an interview with a cocaine-dependent person, and she's showing him, it was no cost to him because he was a research participant. She's showing him brain scans about how messed up his brain is because of his cocaine, and they do an interview at her there later on, and he says, well, I don't think it's all that bad. So, whether visual feedback that you're losing it is all that helpful or not. I suspect that what's underutilized is urine testing. I suspect that, and these days there's point of care urine testing. There are dipsticks. You can collect the urine from somebody and see what's going on.
What would you recommend as appropriate intervention approach for alcohol addiction in an assisted living setting with very few treatment options in the city?
I would consider trying to put together a program within that assisted living facility so that a trained clinician, an addiction counselor, a nurse with addiction experience would have sessions there, could do assessments, could do either individual counseling, perhaps put together a group. I'd try to locate or even help formulate. I'd reach out to the fellowship support group community to see if there wasn't some opportunity for the establishment of a fellowship support group at that particular facility, chaired by somebody of age.
Some persons become more violent when using alcohol. Is this hereditary, more common in particular ethnic groups, personality?
Alcohol disinhibits behavior. So a person that has aggression is more likely to be aggressive when under the influence of alcohol. And you see that with batterers, for example. Batterers that are involved in that behavior are more likely to be batterers when they're under the influence. It's that disinhibiting effect. Nobody's quite sure what it is that causes it, but by the same token, it's much less likely that somebody that has no history of physical violence will become violent under the effects of alcohol. It's not certain, but it's not very likely.
So Angela is also mentioning that Al-Anon is also an option to help families cope with loved ones who are addicted.
Excellent point.
And most addicts I have come in contact with through foster care do not have access to care because they don't have health insurance to get the help they need. What would you suggest for them? This kind of care is very costly.
It's my hope that the Affordable Care Act will bring health insurance to these individuals. The addiction treatment field is bracing itself for an influx of patients that would heretofore not have access care simply because they didn't have the funding to get to it. That to get Medicaid, for example, you had to be disabled medically or psychiatrically. Now it's just you're poor and you can get it. So that's what my hope is.
Comment, I have seen an increase in doctors overprescribing multiple meds for elders.
Yep.
And then the rest is just thank you. They hope that there will be a continuation of this topic next year.
Well, thanks. I'd love to come back. I really appreciate everybody's attention and great questions, and thanks for hanging in there through our little emergency, whatever that was.
Any questions from the audience here? Which you'll need to repeat.
Okay. Thanks for coming, guys.